Good evening to all. On behalf of TNFOG, I welcome you all. Today's the topic is multiple pregnancy by KMC PGs and the external teachers being Dr. Vani from Balaji and Dr. Vijayalakshmi from Chettinadu, and internal being Dr. Vanita and Dr. Shanti from KMC. This is our 9th Bodhana PG class. So we used to conduct this on last Saturday of every month. Since UFOXY is there, we have preponed it to today. So all PGs please continuously participate in this Bodhana class. Now I hand over the mic to Dr. Kalpana, who is the coordinator for our PG class.
Thank you, ma'am. Good evening, everyone. This Bodhana is a 10th PG case discussion. Great initiative by our TNFOG team, Sampath Madam, Secretary, and Anjalakshmi Madam, President. And we have learned externals, Dr. Vani Madam and Dr. Vijayalakshmi Madam, and experienced internals, Dr. Vanita Ma'am and Dr. Shanti Ma'am. We welcome you all. And this program will be definitely useful for the PGs. It's my pleasure to invite our President TNFOG.
Good evening, Kalpana.
Who is a founder president TNFOG, past president of OXY, governing council member of DIPSI. She is a PhD holder in pregnancy diabetology from MGR University, recipient of Best Doctor Award from IMA, retired professor from Madras Medical College, presented many papers in national international conferences, and had done extensive research work in GDM, diagnostic test, and OHA in GDM. Over to you, madam, for welcome address.
Thank you, Kalpana. Good evening to everyone. See, this is, as said, it is the 10th Bodhana program. It's meant to actually improve or empower the postgraduates' knowledge so that they can face the exam without any fear. So today's topic is the twins multiple pregnancy. Actually, with the single pregnancy itself, we have some pregnancy complications. When it becomes double, it becomes a double trouble. And especially when it is a single chorion, then the trouble is more. So I request the postgraduates to keenly watch the program and clarify. The main purpose of this Bodhana is, it is like your home. You can clarify all your doubts so that in the exam, you should not have any doubt. So don't think what doubt you have is a silly, whether somebody will think bad about it. Don't have that inhibition at all. You clarify your doubts, however silly it is, don't worry about it. For that, we have the excellent teachers, your parent teachers like Dr. Vani and Dr. Shanti, and the external teachers, parent teachers Vanita and Dr. Shanti, external teachers Dr. Vani and Dr. Vijayalakshmi. All four of them are well-experienced teachers, and they can clarify all your doubts, and you should know how to care about this twin pregnancy and monitor them and deliver them without any problem, without increase in the perinatal morbidity or mortality. Okay. I welcome all the teachers once again. Thank you very much.
Thank you, madam.
Thank you, ma'am, for your welcome address. Now, it's my pleasure to welcome our internal examiners, Vanita ma'am. Technical team, can you please project Vanita ma'am's profile? Vanita ma'am is a professor and HOD, Kilpak Medical College, and she had undergone fetal medicine training in RSRM Hospital and also trained in microsurgical recanalization. Madam's interest is high-risk obstetrics. Welcome you, ma'am. Our next internal is Shanti ma'am, who is also a professor in Government Kilpak Medical College. She has been a teacher for almost 18 years. Welcome you, ma'am.
Thank you.
Our external teachers are Dr. Vani ma'am, who is who has worked as a HOD in various medical colleges and retired as dean from Tiruvannamalai Medical College. Currently, ma'am is HOD of Sri Balaji Medical College Hospital and published many papers in national and international journals. Welcome you, ma'am.
Thank you.
Our next external is Vijayalakshmi ma'am, who is a professor in Chettinad Medical College Hospital. And she has got also rich experience, almost 16 years of teaching experience for UG and PG. And she has been a mentor for several students, and she's a past EC member, OGSI, and her areas of interest is high-risk obstetrics, adolescent gynecology, infertility, and gynec endoscopy. Welcome you, ma'am.
Thank you, madam.
Our presenter is Dr. Abhinaya, who is a third year PG from Kilpak Medical College, and co-presenter is Dr. Lavanya. She's also third year PG from Kilpak Medical College, and they are going to present about multiple pregnancy. Over to you, presenters. Technical team, you can share the PPT, I think.
Yes, ma'am.
Dr. Abhinaya?
Start, ma'am.
Yeah, you have to increase your volume, or the voice is feeble.
Am I audible now, ma'am?
Yes, better.
Yes, ma'am. Good evening, one and all. Topic today is
Vani madam, காதுல விழுதா? விழுதா? சரி.
இல்ல வால்யூம் கொஞ்சம் கம்மியா தான் இருக்கு மேடம்.
கரெக்ட்டா தான் இருக்குது.
Okay, then you press.
this ex 30-year-old residing at Kundratur, who's a homemaker, studied up to 5th standard, belonging to socio-economic class 4, according to modified scale.
Abhinaya ma'am, it's not audible, ma'am.
போகுது கீழ.
உங்க சிஸ்டம்ல வால்யூம் கொஞ்சம் இன்க்ரீஸ் பண்ணிடுங்க. F10, F11, F12.
Can you hear me now, ma'am?
Feeble, no. Please come nearer to the laptop and.
Ma'am, is it audible now, ma'am?
Now yes, it's better.
Mrs. X, 30-year-old, residing at Kundratur, who's a homemaker, studied up to 5th standard, belonging to socio-economic class 4, according to modified Kuppasamy scale. A case of primary gravida, married since 1 year, booked and immunized at home. Last menstrual period was 15/8/2021. Expected date of delivery is 22/5/2022. Gestational age of 36 weeks plus 2 days. Next slide, ma'am. Presenting complaints, a primary gravida with twin gestation, 36 weeks plus 2 days, with an LMP on 15/8/2021 and EDD on 22/5/2022, presented with complaints of bilateral swelling of legs for the past 1 week, but referred to KMCH for the same from Kundratur. Next, history of presenting illness. Patient presented with history of bilateral swelling of legs for 1 week duration, relieved by rest, able to perceive fetal movements.
The slide is not changing, ma. Okay, proceed.
Able to perceive fetal movements well, no history of pain abdomen, no history of bleeding per vagina or leaking per vagina, no history of headache, vomiting, blurring of vision, epigastric pain, reduced urine output, no history of contraceptive usage, no history of EC fatigability, breathlessness, or palpitation. Vaccinated with 2 doses of Covishield vaccine. Next slide. Menstrual history. Attained menarche at 13 years of age, regular menstrual cycle, 3 to 4 days, 28 days cycle, regular with moderate flow, changes 4 parts per day, not associated with clots. LMP was on 15/8/2021, no history of contraceptive usage. Marital history. Married since 1 year, non-consanguineous marriage. Next. Obstetric history. First trimester, spontaneous conception. Urine pregnancy test was positive at 40 days of amenorrhea. Booked and immunized at Kundratur. Dating scan at 17 weeks confirmed. Twin gestation. Tablet folic acid was taken regularly. NT scan done at 11 weeks was normal.
Abhinaya, a little doubt, ma. Dr. Vijayalakshmi here. Would you call the scan that is done at 17 weeks as a dating scan?
11 weeks.
7 weeks.
Okay.
7 weeks.
You said 7 weeks. Okay, fine. I heard it as 17. That is why. Your
NT
slides are not very clear.
no history of fever, no history of excessive vomiting, no history of spotting or bleeding per vagina, no history of urinary tract or upper respiratory tract infection, no history of radiation exposure or drug intake. Next.
See, NT scan done at 11 weeks. When you done a scan, NT scan, ma?
Ma'am, 11 weeks, 11 to 14 weeks, ma'am.
After 11 weeks to 40, which is a correct period to do NT scan. What are the things you want to see in a twin pregnancy around in NT scan?
Ma'am, would like to do NT scan at 11 weeks to 13 weeks plus 6 days, ma'am.
Okay.
The scan confirms the number of sac, chorionicity in gestational multiple gestation, and number of placenta, the intertwin membrane, and the number of layers between the amniotic sac, ma'am.
Okay, you collectively said TCDA twin. Okay. Okay, ma, continue.
Second trimester, weakening felt at 4th month of gestation, iron and calcium tablets taken regularly, blood pressure monitoring done regularly, injection TD 2 doses were given, anomaly scan at 20 weeks showed no major congenital anomalies. Patient had moderate anemia of HB 9.8 and was treated with 4 doses of iron sucrose at 26 weeks of gestation. OGCT done at 24 weeks was normal, 108 mg per deciliter. No history of pain abdomen, bleeding or PV. No history of easy fatigability, breathlessness, chest pain, fever or burning maturation. No history of vomiting, epigastric pain, headache, blurring of vision or decreased urine output.
What is the recommendation, Abhinaya, for your OGCT in this particular patient?
Ma'am, multiple gestation has a risk of gestational diabetes, ma'am. Because of the increase in the size and the number of placenta, there's an increased anti-insulin hormone secreting from placenta, ma'am.
Yeah. So actually, when would you like to do your OGCT?
Cert, ma'am, and then again at 24 to 28, and then again in the third trimester.
Yeah. So did she have one at the first booking visit when she had her dating, or at least at the time of her NT scan?
No, ma'am, she didn't have, ma'am. She had her first OGCT done at 24 weeks of gestation.
Only second trimester she did OGCT.
Yes, ma'am.
First trimester she didn't do.
Yes,
Okay. Will you do or not in first trimester?
We'll do, ma'am.
First visit you have to do. Oh, yeah.
Next slide. Third trimester, able to perceive fetal movements well, iron and calcium tablets taken regularly. Repeat HB at 32 weeks showed HB of 10.6. Interval growth scan done and was normal. No history of pain abdomen, leaking.
See, in twin pregnancy, only in the first trimester and second trimester and third trimester you will do scan. How will you monitor your twin pregnancy?
Ma'am, in DCDA twins, usually we start monitoring at 20 weeks of gestational age, and every 4 weeks would like to see the growth scan. And in MCDA twins or monochorionic twins, we'll start the screening surveillance from 16 weeks of gestation. And every 2 weeks, USG is done.
But this patient is a booked patient, but done scan only after 24 weeks. I mean 20 weeks. After that, 32 weeks only. In between,
done scan at 28 weeks, 32 weeks, and 36 weeks.
Shall
I proceed?
Yeah.
No.
At each scan, what are you looking for, ma?
The optimum, the growth of the baby, ma'am, the amniotic fluid, in case of monochorionic twins, along with USG, we have to do Doppler, ma'am. Umbilical artery Doppler, then MCA Doppler, ma'am.
Yeah, go on.
No history of pain abdomen, leaking or bleeding PV. No history of nausea, vomiting, headache or blurring of vision. Patient developed bilateral swelling of legs for 1 week and hence referred to KMCH for further management. Next slide. Past history. Not a known case of diabetes, hypertension, bronchial asthma, thyroid disease, heart disease or epilepsy. No previous history of any blood transfusions or surgical history. Personal history, she takes mixed diet, normal bowel and bladder habits, good sleep and normal appetite, no history of any substance abuse. Family history, no history of twinning in the family, nil significant family history. Summary, 30
Recording in progress. Recording in progress. Recording in progress. Recording in progress.
30-year-old primi gravida, married since 1 year, spontaneous conception with DCDA twins with moderate anemia treated, presented with complaints of bilateral pedal edema. Her LMP was 15/8/2021, EDT was on 22/5/2022, at present 36 weeks plus 2 days. General examination, moderately built and nourished, comfortable, not dyspneic or tachypneic, afebrile, no failure, bilateral grade 1 pedal edema present. Height 160 centimeters, pre-pregnancy weight 60 kgs, pre-pregnancy BMI is 23.4, weight gain in pregnancy is 17 kg, BP 110/80 mmHg measured in the left arm in sitting position, pulse rate 90 beats per minute, regular in rhythm and good volume. Respiratory rate is 18 breaths per minute. Urine albumin by dipstick was nil. Thyroid, breast, spine and gait examination normal. Systemic examination, cardiovascular system, S1, S2 normal, no murmurs. Respiratory system, normal vesicular breath sounds, no added sounds. Peritoneal examination, on inspection, the uterus over-distended for gestational age, umbilicus flushed with the surface, tinea nigra and stria gravidarum present, all quadrants equally with respiration, no scars, sinuses or dilated veins seen. Palpation, uterus over-distended for gestational age, the fundal height 36 weeks with flanks full, not acting. Fundal grip, a broad, non-palatable mass suggestive of breech press, and on the umbilical grip, multiple fetal parts present, 3 fetal poles felt. First pelvic grip, smooth, hard, globular, independently velotable structure suggestive of fetal head, palpable per abdomen. Clinically adequate like a auscultation, 2 fetal heart sounds heard, measured simultaneously by 2 observers. Fetal heart sound 130 to 140 beats per minute and second fetal heart sound is 140 to 150 breaths per minute. Local examination, external genitalia appears normal and no abnormal discharge. Summary, 30-year-old primi gravida with 36 weeks plus 2 days of gestation, spontaneous conception with DCDA twins and antenatal anemia treated. On examination, bilateral pedal edema present and perabdomen examination suggestive of multifetal gestation with first twin being cephalic in presentation, good fetal heart for further evaluation and management. Diagnosis, 30-year-old primi gravida, DCDA twins with 36 weeks plus 2 days of gestation with antenatal anemia treated, presented with bilateral pedal edema.
This is spontaneous conception. Okay. So which is the commonest type of twin you come across, which is common?
Dichorionic.
Dicyclic. It is a dicyclic is very common. What is the percentage of dicyclic twin?
75%, ma'am, and 25% monochorionic twins.
Okay. So what is the incidence of twin pregnancy now in worldwide? What is the incidence?
3%, ma'am.
Huh?
3%, ma'am. Incidence of twin pregnancy.
3%. Huh?
Between yes, sir. Between the two, which is common world over, which type of twinning is probably common world over in the sense around the same incidence. What type of twin?
Dichorionic is common overall, ma'am.
No, I'm talking about if you are looking at monozygotic and dizygotic twins, isn't it? Yeah. So between the two, which has a common incidence? Somebody is typing out the answers in the chat box as well.
Monozygotic twins.
Monozygotic twins, almost something like 1 in 250 to 1 in 300 throughout the world. That is what you would see. No, you said there is bilateral pitting fetal edema. In addition to that, so a twin pregnancy comes with this history of pitting fetal edema. What else have you looked at? What are your other findings?
To rule out anemia, ma'am, in the same patient.
Yes.
And hypertension, ma'am, increased incidence of gestational hypertension in multiple pregnancy.
So can you just look at the cutoff of 140/90, or would you like to go through her records and see? What is her blood pressure now that you have checked?
110/80 mmHg, ma'am.
Apart from anemia, any other reason for her fetal edema?
It can also be physiological, ma'am. Because the fetal edema which she presented with got relieved by rest, ma'am.
Now admitted, how would you like to manage her?
I would like to go about investigating the patient, ma'am. Routine investigations like CBC for her hemoglobin status, platelet, and also the other things like hematocrit, and PIH investigations like RFT, FFT, or uric acid, ma'am. Then spot PCR I would like to do, ma'am. Then again USG to confirm her, to look for the Doppler and the status of growth of both the babies.
Urine routine and
in USG particularly, what are you looking at? Because she is 36 plus weeks now, isn't it?
Any growth discordance, and if one of the babies has poly or oligo, ma'am.
Most important will be the presentation, isn't it? She's 36 weeks. You have to plan delivery for her. So your first answer should be, you're going to look at, even though clinically you felt that it was cephalic, the first of the twin was cephalic, sometimes with an over-distended uterus like this, you might be mistaken, isn't it? So you have to confirm your presentation of both the twins. And what else?
the amniotic fluid level, ma'am.
Yes. So in the amniotic fluid, what are you basically looking at? How are you going to describe the adequacy of the amniotic fluid when it is a twin gestation?
Ma'am, the mean vertical pocket, if it is more than 2, it is adequate, ma'am.
So you will go for the single vertical pocket measurements and express the, and what else? What is the other component when you're doing your ultrasound that you will see? Placenta, isn't it? You do not know where the placenta is, whether it is a single fused placenta, which is large and probably even encroaching into the lower segment, or whether they are two separate placentae attached to different, the anterior and posterior walls. So these are three important factors, and you also have to look at the estimated fetal weight. So you are going to do your biometry and assess the fetal weight for both the twins.
What are the complications you expect, ma'am? Major complications of multiple pregnancy from every trimester we will be looking at. What are the major complications for maternal complication and fetal complication for twin pregnancy you will be watching?
First trimester, there can be spontaneous abortions, anemia, hyperemesis, and vanishing twin syndrome, ma'am. In the second trimester, again anemia and hyperemesis gravidarum can persist in the second trimester also, ma'am. And in the second trimester, cervical insufficiency, preterm birth, pressure symptoms like pressure on the breathlessness and pedal edema can happen, ma'am. And increased incidence of preeclampsia and diabetes is more common in second trimester. And third trimester, again anemia, abruption can happen, PROM can happen, and preterm births are common, ma'am, in the second trimester. Intrapartum, PROM, cord prolapse, prolonged pregnancy, and abruption is common. And
Prolonged
post,
pregnancy?
ma'am,
Prolonged pregnancy or something else which is prolonged?
Prolonged labor.
Prolonged labor, ma'am.
And do not forget placenta. Do not forget the placenta in twins.
Postpartum, PPH, and subinvolution, infection, and lactation failure, ma'am.
Any other complication with the placenta in the third stage?
There can also be placenta previa,
Abruption.
abruption placenta.
The third stage.
Listen to what madam is asking. In the third stage, she has said.
Manual removal of placenta.
Why manual removal? She said placenta. If the large placenta, what will happen? Twin pregnancy after placenta removal.
PPH.
Sometimes it can be retained. Because of the atonicity, it can be a retained placenta. Okay.
In fetal complications, ma'am, the fetus due to prematurity can have complications. Also, there might be asphyxia.
Whenever you're talking about fetal complications, you classify
Suppose they say you are
monochorionic twins, unique.
Monochorionic.
Like that, you have to describe.
Yes, ma'am. In MCDA, we'll have TTTS, ma'am, twin to twin transfusion syndrome, TRAP, ma'am, twin reversed arterial perfusion syndrome, ma'am, and then MCMA, monochorionic, monoamniotic, cord entanglement, and interlocking of twins is common, ma'am.
And single fetal demise and selective fetal growth restriction can happen in monochorionic twins, ma'am.
So if you're looking at a TTTS, as per the
What will you do if there is a single fetal demise, the other fetus is normal? What will you do?
You have to continuously monitor the other fetus, ma'am, and there might
be continuous monitoring. How are you going to do continuous monitoring?
Ma'am, after the demise of the first fetus, the fetal survival.
So it depends.
Fetal surveillance.
It depends on the gestation age.
Gestation age. Okay.
The
and also the
the interval between the death of the fetus and the present age.
And the other thing, what you want to know,
ma'am, that can
whether it's monochorionic or dichorionic.
Yes, that is important.
And theoretically, the patient can also go in for DIC very rarely. So we have to monitor her coagulation profile and platelet.
And after 2 to 3 weeks, MRI is done because the surviving fetus will have a neurological complications like microcephaly and
skeletal anomaly.
So every 2 weeks.
Microcephaly, or what is the complication that neurodevelopment complication that you can see in the surviving twin? Am I audible?
Leukomalacia, ma'am.
Yes, periventricular leukomalacia may be seen, though it is a theoretical risk. But when you have a single fetal demise, what are you going to immediately, or probably when she presents to you, what are you going to do for the mother? What are the investigations you're going to do?
Yes, ma'am. Have to counsel the mother regarding the neurological development in the surviving twin and the risk of spontaneous abortion and risk of spontaneous abortion in the surviving twin, ma'am. I would like to do USG every 2 weeks, ma'am. And after 3 weeks or to 4 weeks, would like to do an MRI and coagulation profile monitoring should be done, and AFI and biophysical profile of the surviving twin, and after the pulmonary maturity, lung maturity at 34 weeks after a course of steroids, will deliver the baby by cesarean section, ma'am.
Any other investigation to detect anemia in the surviving twin? We will add on.
A Doppler,
MCA Doppler should be offered. Please.
So if you're looking at, you were talking about TTTS. How do you grade TTTS?
Winter of staging, ma'am.
Hmm.
Stage 1 is there is an oligopoly sequence. The bladder of the donor twin is visible. Stage 2, where the bladder is not visible, ma'am, with oligopoly sequence. In the stage 3, there is a oligopoly sequence. The donor bladder is not visible, and Doppler changes. There is an increased pulsations in the umbilical. Sorry, increased pulsations in the umbilical artery, and there is
Have a high resistance flow, isn't it? Or even then, sometimes you can even have an absence in the umbilical artery. Okay, ARDTV.
systolic flow, and there can be absence reversal of ductus venosus and increased pulsations in the umbilical vein. Stage 4, there is hydrops in one or both of the fetus. Stage 4, the depth of one or both the fetus.
When will you decide for delivery, ma, for DCTA twins and monochorionic twins? When will you decide for the delivery of the babies?
For uncomplicated DCTA twins, ma'am, we can plan delivery around 27 to 38 weeks, ma'am. And then for uncomplicated monochorionic diamniotic twins, you have to plan around 36 weeks, ma'am. For MCMA twins, 32 to 34 weeks, ma'am. And for
why for twin pregnancy you are deciding at 37 weeks, ma?
Because always twins have mature 2 weeks, 2 to 3 weeks earlier than singleton.
I know. More than 2 weeks, around 3 weeks they have a maturity than the single. Okay. What plan you will do? Will you look for a normal or a vaginal delivery or cesarean?
Depends on the presentation of the first twin, ma'am. If it is
your case,
cephalic, I would like to go for vaginal delivery, ma'am. And also, I will also look after the presentation of the second twin also. And
when did we see the presentation of the second twin? Now we know this. After
of the first twin, ma'am.
Okay. What clinically? How will you? What examination you will do?
Ma'am, after
abdominal or vaginal?
Abdominal, ma'am.
Suppose. Okay. Of the second twin is breech.
Ma'am, then breech extraction can be done, ma'am.
Breech extraction, ma'am.
Why?
You go for a breech extraction. Now, how would you conduct the delivery? This patient, you are planning to deliver at 37 plus weeks. So, how would you like to monitor her labor? And how would you like to conduct her
do in a breech?
Ma'am, in first stage of labor, would like to.
No, ma, this is a cephalic. First one is delivered. Now you are doing examination. You find that it's a breech presentation. What first you want to do?
First, would like to confirm the position of the second twin.
What type of, okay, what will you do? Usually breech presentation.
Assisted breech delivery.
Before that, what, anything else?
So membranes are intact.
When the membranes are intact,
can you try anything?
External cephalic version can be done.
Yes. Yes. So first you want to confirm your
position.
The presentation you have to reconfirm by performing an ultrasound. And you've confirmed that it is breech, then you can attempt. So how are you going to attempt to do ECV? This particular patient. She's having uterine contractions because she has just delivered, isn't it?
Ma'am, external cephalic version should be done under anesthesia, ma'am.
You want anesthesia for external cephalic version?
Why do you want anesthesia for ECV?
Epidural anesthesia.
What guidance you will have?
You will give anesthesia, Abhinaya. Which version you will give anesthesia?
ITV will give general anesthesia. For external cephalic version one, epidural analgesia, ma'am.
That is not needed for a version. What else
For
do you
breech
need?
delivery, you can give epidural anesthesia.
Ma'am?
If she's having uterine contractions, what do you need other than your analgesia?
You understand what we are trying to ask you? She has had contraction. She's delivered first of the twin now. And now the second you have identified it to be breech. So you said you want to attempt ECV.
Ma'am, tocolytics.
What are you going to give?
Ma'am, tocolytics and continuous CTG monitoring.
What tocolytic are you going to give? It should be a short acting and should act immediately because you're going to act.
Terpentolin can be given.
How much? What is the route?
0.25 mg, ma'am.
250 micrograms, yes.
Subcutaneous, ma'am.
Subcutaneously. And what do you need when you're going to perform the ECV? You're doing it in the theater, in your second stage, isn't it? In your labor room.
To keep ready for OT team to be ready, ma'am.
Yes.
But at any time, if our procedure fails, we can take the patient for C-section, ma'am.
But you need to have under what guidance? You cannot do a blind ECV at this stage, isn't it?
Yes, ma'am.
Have the ultrasound guidance. And you attempt to do an ECV. If you're not successful and you find that the presentation is continuing to remain as breech.
Checking for the intactness of the membranes, ma'am. If the membranes are intact, we can go in for internal podalic version, ma'am.
Internal podalic version is for which presentation, ma?
When will you do an IPV?
Transfer.
No, here it is the breech. Why do you want internal podalic version?
Why can't you do a safer assisted breech delivery? You can do, isn't it? So you would want to do an assisted breech delivery. And if you plan to conduct an assisted breech delivery, what are you going to do? What are the steps you're going to do here? Second of the twin.
Watch for the uterine contractions, ma'am.
Yes.
Spontaneously, the patient is getting contractions or not. Otherwise, symptom infusion can be started, ma'am. And continuous efforts monitoring will be done, ma'am. And then the patient is allowed to deliver spontaneously until the umbilical, and then cover the breech with the towel in order not to stimulate the. And then
so you keep your membranes intact till you find that the breech has descended well down, isn't it? And then you can do an ARM at that stage and allow for the breech. You would have already conducted the delivery of the first one. You would have given her an episiotomy. So if needed, you can increase the length of your episiotomy as well. Okay, then.
When the baby reaches the nape of the neck, I shall do Burns-Marshall technique or Morrissey's belly weaves technique and deliver the baby.
To deliver the arms, isn't it?
Losec maneuver for extended arms. If it's extended, I'll do Losec maneuver. And then for the head, Burns-Marshall or Morrissey's belly weave technique.
So as madam was saying, what is the role for IPV when you're delivering twins?
In multiple presentation for the second twin in transverse presentation.
It is not a presentation. Transverse is a
transverse lie. Okay, so don't say presentation. So the only role for IPV in modern obstetrics is when you want to do a for the second of the twin in a transverse line.
What are the problem you can come across, ma, when you are doing IPV?
It can be your cord prolapse, ma'am. Rupture of membranes, cord prolapse.
You do not do IPV, isn't it? It is an internal maneuver, internal podalic version. It's an internal maneuver. So if you have intact membranes, how can you do an internal maneuver like that?
Already you have done, you have ruptured the membrane, taken the baby, everything is done.
You have to do?
What are the complications you can come across when you are taking the IPV and are doing IPV? Abhinaya, can you hear? What are the complications you can get during IPV?
Bleeding, ma'am, abruption, uterine rupture, and
Rupture. And abruption, that is what you'll be worried about. So if there's a suspicion of or a difficult IPV, what would you like to do? And how can you get the help for performing the IPV? What would you need? Because it is an internal maneuver. You have to introduce your hand in to identify the breach and maneuver it down, isn't it? So, yeah, what anesthesia?
General anesthesia in OT it is done.
Yes. So you have to ask for GA so that there will be good uterine relaxation. You can go in and do a version and follow it with a
What extraction?
Breech extraction.
Breech extraction. So you have to completely say the whole statement. So you will do all the maneuvers yourself. You're going to do a full total breech extraction.
Can you tell me the difference between assisted breech delivery and breech extraction?
Assisted breech delivery, ma'am, the baby is allowed to deliver till the umbilicus, and then the assistance is needed for the shoulders and the arms and the head of the baby, ma'am. While in breech extraction, the delivery is the obstetrician in breech extraction, the obstetrician does the whole maneuvers, ma'am, from the breech, leg, the arms. And
okay. Coming to TTTS. Supposing you have identified TTTS, how would you like to manage this patient?
16 weeks. 16 weeks.
Not at 16 weeks, at 22 weeks, 24 weeks, 22 to 24 weeks.
Ma'am, at 22 to 24 weeks, if it is stage 1, ma'am, then expected management can be done. Doppler can be done every 2 weeks, ma'am, and close surveillance with the USG. If it is stage 2 to stage 4 and the fetus is less than 26 weeks, we'll go with fetoscopic laser coagulation of the anastomosis, ma'am. If it is more than 24 weeks, then amnioreduction can be done, ma'am. And if one of the fetus is there any anomaly, then we can go for selective feticide, ma'am. And septostomy is done, but it has its own risk, ma'am. So it is not preferred nowadays.
So, and you should also not say selective fetal termination at this stage.
Fetal bipolar coagulation of the arteries, umbilical cord.
Suppose you want both the babies alive, then you can do only, which better you do which procedure?
Laser photocoagulation.
What is the recent technique with which they do?
Technique.
Yes. How is it done?
The AV anastomosis is identified using ultrasonogram using Doppler, and then the arteriovenous.
Is it identified with ultrasound or something else? Fetoscopy. Under fetoscopy, they visualize the placental equator. Okay.
And then photocoagulation.
Which anastomosis are selected?
Atrial anastomosis. Atriovenous anastomosis.
Which is the reason for the TTTS? Be loud, we are not able to hear you.
Arteriovenous anastomosis, ma'am.
It is a unidirectional flow of blood in the atriovenous anastomosis, while the arterioanastomosis and venovenous anastomosis has been spared, has been observed.
So you have to select the deep AV anastomosis and do the laser photocoagulation. What is the
common complications, Abhinaya and Lavanya, following FLOC?
Ma'am, growth, IUGR, ma'am, IUGR of both the fetuses, ma'am.
Weight restriction. Then what is the iatrogenic induced complication you get following fetoscopic laser occlusion?
Ma'am,
What is that?
vascularization of the placenta, ma'am. So there can be the blood IUGR preterm birth, oligohydramnios can happen, ma'am.
What is TAPS?
When anemia polycythemia sequence, ma'am. In which there is a
Is there an increased incidence following
fetoscopic laser ablation?
Is this complication more following an ablation? Madam is asking.
Yes, ma'am. It is the most common complication following photofibrillation for TTTS, ma'am.
So now coming to discordancy in growth between the twins, how are you going to diagnose? What are the diagnostic criteria?
Diagnosis criteria is by difference in estimated fetal weight of both twins more than 20%, ma'am, and abdominal circumference between more than 2 centimeters. And also the difference in head circumference between both the twins by more than 5%, and biparatal diameter more than 6 millimeter, ma'am. Then ST ratio must be more than, the difference must be more than 25%, ma'am.
So when you have a discordant growth between the twins, how are you going to monitor?
Ma'am, USG surveillance every 2 weeks must be done, ma'am. And umbilical artery Doppler would like to do, ma'am. In umbilical artery Doppler, according to Krakatoa's classification, there are 3 types, ma'am. Type 1, there is an increase. In A1, the increased diastolic flow, ma'am. In type 2, there is reverse or absent diastolic flow. In type 3, there are cyclical waveforms, ma'am. Combining both type 1 and type 2. Type 2 carries the worst prognosis, ma'am. In
be a little loud, Mike. You're not audible.
Ma'am, in type 2 would like to monitor every week, ma'am.
So to do weekly monitoring. And what are you going to base your decision to deliver the twins when you have growth discordance? The Doppler of the
surviving twin, umbilical
discordancy. We're talking about discordant growth. We're not talking about single fetal demise here.
The better one.
The Doppler of the
normal or the growth restricted baby?
I mean, Doppler of the growth restricted baby.
Yes, you have to complete your statements. Okay, you complete your statements. And when will you decide to deliver?
Ma'am, after the lung maturity, ma'am, after a dose of corticosteroids, at 34 weeks, would like to do elective cesarean section, ma'am.
No. MCMA twins. What is its incidence?
Less than 1%.
So how are you going to monitor?
In MCMA, the surveillance starts by 16 weeks, ma'am. And every 2 weeks, the USG surveillance, Doppler of the baby and amniotic fluid and modified biophysical profile must be started from 28 weeks, ma'am. And in most common complication which occurs in MCMA twin is cord entanglement. So would like to monitor the baby, and after 32 to 34 weeks after the course of steroids, elective cesarean section can be done.
Vani madam, any questions?
Yeah, how will you post-op detail? How will you The two babies are there, no? How will you give the post-operative care or mother feeding? What are the method to give feeding for the both the babies, ma?
Ma'am,
For,
breastfeeding.
Yeah,
Breast-
breastfeeding only. How will you give breastfeeding?
Ma'am, breastfeeding can be given for both the babies, ma'am. After the
What
breastfeeding,
are the methods you can adopt for the babies? You can
Uh,
teach.
football method.
technique, ma'am.
Call technique.
Technique. Then
Probably you can take recourse to breast milk bank as well. Isn't it?
are they? Abhinaya, are you there?
Yes, ma'am.
Yeah. What is the other risk, ma, during that multiple gestation, during delivery? Any important risk for the mother? They are more prone for that emergency things. It's obstetric emergency.
PPH, ma'am.
More than that, anything else? They are
Ma'am,
more.
abruption and PPH, ma'am.
Okay. Any amniotic fluid embolism are they prone for?
Yes, ma'am.
Twin and preeclampsia, all that. Post-operative care for the twin pregnancy. When will you do cesarean section? What are the indication for cesarean section in multiple pregnancy?
Ma'am,
The first one, non-vortex first one, ma'am. And then there's
CPD, suspected CPD.
and then discordant growth in both the twins, single fetal device, ma'am.
Multiple gestation.
Higher order station, isn't it?
Yeah. More than two gestation also. Then hello.
Yes, ma'am.
Okay. Twin to twin transfusion.
Twin to twin transfusion, selective fetal growth restriction, single fetal device, ma'am.
Okay.
Anything else?
Conjoined twins, ma'am.
Conjoined.
Monoamniotic.
Yes, ma'am.
CMA twins, isn't it? Huh? So you have those 7 or 8 indications which you should tell in order where you would prefer to do an elective cesarean delivery. What is fetus papyraceous? I never heard that word from both of you.
Ma'am, it is the death of one fetus after 14 weeks, and that fetus gets compressed and gets stick to the other twin. It is not, mostly it will not
Stuck
disturb
to the other twin or where? Stuck where?
Wall, ma'am.
Against
in the
the
membrane.
and when does it get expelled?
During the delivery of the surviving twin, ma'am.
At the time of delivery of the placenta, isn't it? It comes mummified.
In first trimester, is there any role for aspirin? When do you give that?
Risk factors, we can start the patient on aspirin. The risk factors are higher maternal age, more than 35 or 40 years. I think family history of preeclampsia.
Maternal weight more than 35 kg. And the interpregnancy interval is more than
So does this patient qualify for a low dose aspirin if she comes in the first trimester?
Yes, ma'am.
Which are the moderate risk factors you have identified?
Here we have a she's primary, ma'am.
with
primary and twins. Okay.
Primary
So
and
two moderate risk factors are present.
30 years.
When will you reveal to the patient that she has twin pregnancy? When you're doing your dating scan. You're doing a scan at 6 weeks. Will you be able to tell for sure that it is twins?
No, ma'am. There is instance of 20% the twin can go in for vanishing twin syndrome, ma'am. So after confirming it by the next ultrasound,
When will you do the next ultrasound?
Ma'am, at 11 NT scan, ma'am.
6 weeks you have seen, you're suspecting twins. Will you wait till 11 weeks?
8 weeks, ma'am.
Around, yes, 8 to 9 weeks. And what you have to see to confirm and say that yes, it is twin, and what are you going to look at that stage?
2 separate sacs separated by a intimate membrane, ma'am.
Okay, and
the thickness, ma'am.
yeah, and you have to identify the fetal heart. Both the fetal hearts you have to identify for you to confirm and tell the patient, reveal to the patient that she has. So till 8 to 9 weeks, you have to be wary before you disclose to the patient that you have twin gestation. So what is this lambda sign? What is the
Lambda sign is a twin peak sign, which is seen in dichorionic diamniotic baby diamniotic twins, ma'am, because of the infolding of the intertwined membrane, ma'am. While T sign is seen in
monochorionic. The
monochorionic
infolding of the membrane, or what else you will see? Why is that
peaking
occur? Huh?
Chorions, ma'am. It is because of the growth of the trophoblastic tissue that forms the lambda, which is lambda sign or twin peak sign.
So when is the time to identify this lambda sign? Which is the best time that you can
11
clearly? So you wait till beyond 13 weeks in the second trimester and all, it's very difficult for you to clearly say. So you have to do it when you're doing your nuchal transfusion. So between 11.5 to 13 weeks and 6 days. Okay. What is the other sign which can tell you that it is probably a chorionic twin?
T sign for monochorionic monochorionic twins, ma'am.
Apart from chorionicity and amnionicity, any other thing you will like to do in 11 to 14 weeks?
Placenta can be seen, ma'am. 2 placentas and
yeah, that is placenta. 2 placentas, dichorionic. What else?
Septal thickness, ma'am. If it's more
septal thickness. Okay, then you should assign
what you see in the septal thickness. What you will see?
4 layers in case of DCDA, ma'am. 2 chorion layer and 2 amniotic layers, ma'am. Whereas in case of monochorionic, we'll be seeing only the 2 amniotic layers, ma'am.
So under high resolution ultrasound, you need to zoom and see the layers.
Suppose you miss your chorionicity by 11 weeks, how will you diagnose your chorionicity, ma?
At a later, say at anomaly scan. What are the pointers towards a DCDA when you are looking at her only during that time?
If both the fetus are of different sex, it confirms dichorionicity, ma'am. If there are 2 placentas, if the placentas are
separate placenta.
How will you name the twins in the 11 to 14 week scan?
The one which is
the cervical is twin A and the twin B is above it, or you can name it as left and the right, or upper or the lower.
Okay.
If
that
the
also
NT
should be assigned.
If the NT is increased in your scan at this time, what else you suspect other than your congenital anomalies, chromosomal anomalies?
It is the first sign of twin to twin transfusion syndrome, and so would like to proceed with the amniocentesis, ma'am.
Suppose it's a DCDA and still it's increased.
Ma'am, first have to confirm the gestational age, ma'am. If the gestational
what are the other causes for NT increase other than chromosomal anomalies?
TTTS, ma'am.
TTTS and MCDA, okay.
In dichorionic?
In monochorionic twins. Suppose if it's increased, then cardiac anomalies, severe cardiac malformation can also lead to increase in nuchal translucency. Okay, apart from chromosomal anomalies. How do you screen for chromosomal anomalies? Having come to
now that
First trimester, combined test can be done, ma'am. NT scan, beta HCG, and pregnancy associated plasma protein A.
can you do that for this twin gestation?
No, ma'am. As because there's there's two in multiple gestation, beta HCG is going to be high, ma'am. So we can't rely on beta HCG, ma'am. So we have to go with if the nuchal translucency is increased, we'll go with the amniocentesis, ma'am. If
So you have to do invasive. Yes. Okay. So you cannot rely on your hormones. Okay. You cannot just rely on your beta HCG and PAP-A as you would do with a singleton pregnancy.
invasive testing, should you offer for both the DA twins or only the affected twins?
case of DCDA, both should be done.
Both should be done.
So if you're looking at higher order multiple pregnancy, looking at quadruplet, what is the recommendation? What should we do? It is possible, isn't it? What are the reasons for higher order
It's more
multiple
than
pregnancy?
22 pregnancy, higher order. What will you do?
Ma'am, it is increased because of increase in assisted reproductive technique, ma'am. So in order to if the mother is okay, the mother can be counseled and selective fetal reduction can be done, ma'am, in the first trimester.
Fetal reduction is recommended for what?
Ma'am, recommended for quadruplets, ma'am. If one of the baby is, if the one of the baby is reduced, the chance of increasing pregnancy to extra 3 weeks is possible. So I would counsel the mother and can go with fetal reduction at 11 to 14 weeks.
Can you go for a fetal reduction when you're having triplets?
Yes, ma'am.
So if you have triplets and you're going for reduction, what are the criteria you have to see? And which of the fetus will you choose for reduction?
Anomaly scan must be.
No. Will you be doing a reduction at that time?
11 to 14 weeks will do reduction, ma'am.
14 weeks is a little too late. You cannot do reduction at that stage. Why? She might end up losing all the fetuses. Okay. So first you have to identify the chorionicity. Are we looking at a trichorionic, triamniotic type or a DCTA with a singleton? So that has to be identified and you will choose which will you choose between the three?
If we choose the singleton, ma'am, monochlinic, monoamniotic, or dichorionic will survive, ma'am. But still, it has disadvantages. MC monochlinic will have its own complications, ma'am.
And what is the procedure? How is the procedure done?
Under ultrasound guidance, the potassium chloride is injected into the intracardiac injection of potassium chloride, ma'am.
Intracardiac KCL injection. And
what is the new this thing, what to avoid this hierarchy pregnancy?
Single embryo transfer, ma'am.
Single embryo, huh?
yes.
Single or double embryo?
Double embryo, ma'am.
Only 2 embryos should be now.
More than 2 embryos. Never more than 2 embryos. But in certain centers, they even go for a single embryo transfer.
Single embryo.
But even with single embryo transfer, is there a possibility of twins?
Yes, ma'am.
Yes.
We can ensure the blastocyst so that it splits into 2 and we get twins, ma'am.
Okay, you can have. We do encounter that many times.
How do you screen for cervical incompetence?
Ma'am,
Preterm labor predictions.
at 16 to 24, at 24 weeks, the cervical length is less than 1.7.
24 weeks, is it?
24, ma'am.
20 to
20
24.
too late? Huh?
20 weeks, ma'am.
When will you screen? Especially with the twin gestation.
24 weeks, ma'am.
20.
Vanita, madam, they want to wait till 24 weeks.
Little early, 4 weeks earlier we can start.
Okay.
16.
Okay, then what about the length?
Ma'am, then cervical length less than 1.5 centimeters in
1.5?
multiple pregnancy.
Multiple pregnancy.
Multiple
What is the
pregnancy.
cutoff?
In normal
Normal is,
pregnancy, it is 2.5 centimeters, ma'am. Less than 2.5 centimeters at 24 weeks says it is cervical insufficiency. In multiple pregnancy at 16 to 20
We are
weeks,
not asking for insufficiency. We are asking the predicting for preterm labor. Madam is asking for prediction of preterm labor.
cervical length.
For predicting the preterm labor.
Cervical length should be less than 2.5 centimeters, ma'am.
Other
Then
than cervical length, will you see anything else?
What else will do?
Fibronectin can be done.
Which will increase the predictivity.
Fetal,
Yes, fetal?
fetal fibronectin, ma'am.
Yes. Any value for that or presence is enough?
More than 15 nanogram per deciliter, we can predict a preterm delivery, ma'am. Preterm labor, ma'am.
Any role? How are you going to prevent once predicted?
Ma'am, in multiple pregnancy, there's no role for tocolytics or rest or cervical encirclage, ma'am. So you can, if the baby is more than 28 weeks, then course of steroids can be given and institution delivery with skilled obstetrician and with institution with a good neonatal care must be selected, ma'am.
What is the role for routine cervical encerclage in twin pregnancies?
There's
Your idea on that?
No
There is
routine
no role, ma'am.
cervical encerclage in.
Supposing, so you will serially monitor the cervical length. If you find that there's a slight shortening, how would you like to monitor the pregnancy and how would you like to treat her? What is the recommendation? What can be given? What is the ACOG recommendation for that?
Ma'am, bed rest, avoidance of extraneous activities.
Bed rest and that is for this or is for something else? Associated complications only you do that. Not for the length, short length.
So vaginal progesterone. Okay, so vaginal progesterone, intravaginal progesterone can be given. Micronized progesterone.
Can emergency circlage be done for them if the cervix is around 1.5 centimeter?
There's no recommendation for encerclage and multiple.
There's no role for
but you leave it.
prophylactic circlage, but when there is
It's
a
emergency
dilatation,
rescue.
You cannot just
rescue
tell the
circlage.
patient.
There is a small role for rescue circlage. It has been proved to be beneficial in twins once it crosses 1.5 centimeter.
Do you have anything else other than your circlage procedure?
Ma'am, pessary can be.
What
Can you tell
pessary is
the
that?
name of it?
Arabian pessary.
Yes.
But here there is no role for Arabian pessary in twins.
What is the recommendation you're going to give as regards diet for this patient with twin gestation?
For 300 kilocalories must be taken for twin gestation, ma'am.
And
then,
iron supplements 10 to 20.
10 to 20 mg per day.
Additional
support, ma'am.
And folic acid 1 mg, ma'am. 1 mg per day, ma'am.
Somebody wanted to know what is that pessary that you will give. One of you tell that loudly.
Arabian.
Arabian.
Arabin. It's ARABIN. Arabin pessary.
Suppose he's not getting into labor at 37 weeks. How do you like to induce her? What is the method?
Based on the Bishop's score, PGE2 gel induction.
Any other thing preferred over PGE2 gel?
Mechanical dilatation under the cover of antibiotics can be given.
Mechanical method is more preferred than your E2 gel.
What is the risk when you're going to go in for pharmacological methods like your PGE2 gel?
Risk for uterine atony, ma'am, and
hyperstimulation of the uterus and
hyperstimulation.
fetal hypoxia, ma'am.
Any other students, any doubts, you can post in the chat box.
How are you going to identify following the delivery and you have a placenta, fused placenta that you have delivered out? How are you going to identify the chorionicity? What can be done? You're not audible, Vinaya and
Lavanya.
Completeness of the membranes can be checked, ma'am, whether the two membranes are separate or they are fused together.
the umbilical cord.
you can actually feel the membranes itself and see. And can you inject something into one of the cords and see? It's there in your Williams, I think. Huh? Injection of some dye, huh? Methylene blue can be injected, isn't it?
Endocarmine dye, ma'am.
You can inject endocarmine dye, yes. It's easily available. What is easily available is methylene blue only, isn't it?
Suppose you have chosen vaginal delivery to induce and she's going into labor. She's not getting adequate contractions. How will you augment? What is the?
The symptom
can be
augmentation can be done.
Is it the same dose?
Same dose as in a
concentrate. We started, ma'am. Ma'am?
Is it the same dose 5 units you give as in a primary or what means you reduce?
Concentrated oxytocin drip must be started, ma'am. 6 milli international units per minute must be given, ma'am.
What you're using even in your singleton?
Ma'am, low dose and high dose, ma'am. Low dose it is 1 to 2.
Would you like to go for the regular 5 units or would you like to halve your dose for augmentation in twin gestation?
We usually add 5 units to 500 ml. In twins, how many units do we add?
Some 5 units and 100 ml of NS can be given.
You want a concentrated one? It is a over.
Or you want to reduce the?
Ma'am, dose of oxytocin is same, ma'am, while the 500 ml RL can be reduced to.
Why you want to give concentrated oxytocin?
More profound. It causes oxytocin causes more profound hypotension, ma'am. Also to prevent hyperstimulation, ma'am.
For that you want a concentrated solution?
We usually go for half the dose. For a primary, we usually put only 2.5 units for a twins. Okay. You can go for concentrate. You don't want to overload.
The reason for going in for a concentrated oxytocin infusion is to prevent overload. But most of the time, you can just add half the dose, 2.5 units, and titrate accordingly. And all the other procedure you can follow is half dose titration. Don't give as you would give in a primary gravida. Half the dose you can keep on titrating.
Can we put in a PPI UCD or is it a contraindication at twin?
We can give.
We can.
What is superfetation? What is superfecundation?
From superfetation, it is a development of a second, it is a second fertilization which is happening in a uterus which already has a, carries a fertilized ovum from the previous cycle, ma'am. This is superfetation. Superfetation is fertilization of two separate ova by the two different sperms, two different act of coitus in the same menstrual cycle, ma'am.
During the same menstrual cycle. What's the incidence of congenital anomalies in twin gestation?
It is 4 to 5% increase than the singleton pregnancies.
Any difference between the monochorionic and dizygotic? Monodizygotic and dizygotic?
In monochorionic, the instance is increased 3 to 5 folds than dichorionic, ma'am.
Yes, twinning itself is an abnormal event. So it
For the sake of completion, tell the various types of conjoined twins.
We have a thoracophagous, ma'am, craniophagous, ratiophagous, pyophagus, ma'am, and the most commonest is thoracophagous, ma'am. Instance of conjoined twins is very, very rare, less than 1%, ma'am.
1%?
Very rare,
Very rare, ma'am. Less than 1%.
1 in 25,000 to 1 in 30,000 live births. Okay.
Okay, now can you summarize usually when the twin or multiple gestation comes, how will you diagnose a multiple gestation?
When will you talk about or declare the chorionicity? And what are you going to do?
History, examination. Can you summarize, Abhinaya?
Ma'am, in the first trimester, if dichorionic, diamniotic twins are diagnosed, then at 11 to 14.
From the history, start from your history. When you will suspect multiple gestation?
Ma'am, if the maternal age is more than 30 and multiparity and history of any IVF conception, artificial reproductive technique has been undergone, then we can suspect multiple pregnancy, ma'am. And family history of multiple pregnancy also plays a role, ma'am. Maternal side twinning plays a role, ma'am.
Okay.
And any history?
History, she
Any
has
any history?
the patient presents with excessive vomiting, ma'am. And also
the pregnancy symptoms will be, including vomiting, will be exaggerated. In the second trimester?
Ma'am, and would like to do fetal surveillance, ma'am. For DCDA twins, from 20 weeks, every 4 weeks, USG and amniotic, the biophysical profile must be done, ma'am.
No, I know. How will you suspect what the monitoring you do? Patient, what is the history they will say? Even though it is old, now you should know what are the history the patient will say when there is a twin pregnancy. What are the examination you will do? What are the changes sequencing?
Ma'am, she can complain of pressure symptoms, ma'am. Pedal edema and breathlessness, and she will have an increased incidence of preeclampsia, ma'am. Preeclampsia and diabetes mellitus. So routine BP monitoring and OGCT.
No, ma'am, the patient symptoms. Second, if it's a multiple pregnancy, she will be having more movements like that. You have to sell the large size abdomen, not able to eat it. Then you have to examine. See for your multiple fetal parts and 3 pole and 2 fetal hearts. Okay. So with that clinical symptom, you can diagnose. Even though you diagnose your twin pregnancy by your ultrasonogram or monitor, you have to diagnose first time. Suppose you see a patient, how to diagnose it. Still are there, no? So many people are not booked and see. You have to diagnose your multiple gestation.
Always think of the clinical. Whenever you're looking at a uterus,
that is
more than the period of gestation, isn't it? So before you rely on ultrasound, that's what madam is saying. You are posted in a remote area. You don't have access to ultrasound. So when are you going to suspect that it could be
See,
And if it is
clinical
twins-
history, your examination, everything is important when you come to a diagnosis. Everything you can just give a scan diagnosis. It may sometimes, as you said, it may sometimes you may not know. Twin pregnancy, if you say at 11 weeks, if there is no twin after 12 weeks or 13 weeks, vanishing twin or papriasis, then they will be blamed. So clinical examination history is very, very important in saying that every time patient comes, you have to examine the patient first clinically. Hello?
Yes, ma'am.
Yeah. Then you are monitoring with ultrasonogram, but your clinical examination is must always.
Yes,
Okay. You should
How will you
ask.
monitor a twin baby? NST. What is the special type of probe you
NST.
should?
Two separate probes, ma'am.
Or NST with the dual probe. What are the indications for LSCS in second of the twin delivering a second?
If there is cord prolapse or a transverse life and prolapse and abruption and fetal distress in the second baby and inadvertent use of oxytocin.
What is the time? Is there any time interval between the delivery of the first baby and second baby?
The ideal time between first and the second twin is 15 minutes, but not exceeding more than 30 minutes.
No.
3 minutes is not a hard and fast rule.
Fast rule.
Provided the progress is happening well, you can wait.
There is a history taking the baby after 24 hours, you can deliver. That is, it depends upon this thing, not immediately. But we have put only 15 minutes and 30 minutes for your convenience. As you said, there is no rule that you have to deliver by 15 minutes or 30 minutes.
Yes, ma'am.
Yes, ma'am.
Suppose your twins get interlocked. First, you have delivered as breech. It's not coming. Then how will you deliver the second twin?
We can use Piper forceps for the second head, ma'am. And while delivering it, hyperextension of the first head takes place and both the twins get delivered, ma'am.
Or
we can
suppose the first twin fetal is not a present. It has died.
Not present, then
Second twin is alive. Then what you can do?
Decapitation of the first twin can be done, and second twin is delivered, and then the head of the
Do we
first.
do all that decapitation and all that? What do we do? If there is difficulty, then what do we do?
Emergency cesarean section is done.
Yes.
Modern obstetrics, there's no role for all this
Surgeries.
destructive procedures.
Surgeries.
We don't very rarely we resort to destructive procedures. So don't say that as your first answer. Okay. You have a live second of the twin. Even if you have the first of the twin is lost, you want to give her at least one live birth, isn't it? So doing all these heroic maneuvers is not going to help. It increases the maternal morbidity and the perinatal morbidity to a great extent, isn't it?
Okay, we finish, huh?
Yes, madam.
Yes.
Lavanya,
Lavanya, any doubts? You can ask the teachers. Well presented.
Ma'am, in case of molar pregnancy, ma'am, if one twin is normal and the other one is molar pregnancy, whether can we continue the pregnancy, ma'am? After explaining the mother about the incidence of preeclampsia and all those things.
Depends on whether you're looking at a partial mole or a complete mole.
Complete mole.
What?
Better to evacuate.
More we have
Does it
advice
increase
from-
the chances of choriocarcinoma in a complete mole?
So it's better to go ahead with the termination. So if you are asked a question that you have a patient with a twin where one of the sac shows a mole and the other is a normal fetus, what is how are you going to counsel the patient and what are you going to do? It's safer to say that you will counsel for termination and terminate the pregnancy.
Yes, ma'am.
Because of the very high risk of her going in for choriocostomy. We have done that. In fact, I have encountered one patient like that.
Yes, madam. We have also encountered.
Yes. But mostly these patients are out of assisted reproductive techniques and they'll not be willing if you want to terminate the pregnancy. If they are not willing, in that case, you have to go with the continuous monitoring, and sometimes we may be lucky in getting a good babe, alive, healthy babe.
Even though we talk about the
Monitoring, number one.
salvageability,
Number two, informed written consent is a very, very important thing that you have to counsel and obtain from the patient periodically.
Even though we talk about salvageability at 34 weeks, nowadays even at 28 weeks with the weight of 1 gram, 1 kilo and 900 grams, also the salvageability is better. So you can terminate the pregnancy at the earliest, monitoring the patient. You can give them light child.
Yes, ma'am. Okay, shall we finish?
Yeah.
Lavanya, good question, Lavanya. கடைசியா அப்படியே ரஜினிகாந்த் மாதிரி கேட்டப்போ
These things should be individualized to the patient's conditions. Hello. Thank you. Thank
What
you
is
so
the
much.
highest recorded inter-twin birth interval? This is something like an MCQ question.
20 years.
20 years.
20 years.
Hey.
21 to 143 days, ma'am.
How many days?
21 to 143 days.
Hey, even here we have recorded more than, I think, 6 months. When I was there, Korean Joseph, one baby was expelled. She was other baby with umbilical cord. They delivered after some 4 months or something. They got
131 days. That was his case.
They got delivered. Yeah.
They're all
Thank you, Sambat. Thank you, Sambat, for your.
Thank you, Vani madam. Thank you.
Thank you, Sambat madam.
For completion,
Vani madam.
Kalpana will give the vote of thanks. Abhinaya, Lavanya, நல்லா பண்ணீங்கப்பா. உங்களுக்கு அந்த TNFOG போட்ட டாலர் வீட்டுக்கு வரும். ஓகே, பிரியான்றவங்க அட்ரஸ் வாங்குவாங்க. அந்த டாலர் வந்து உங்களுக்கு வீட்டுக்கு வரும். Dr.
Thank
Kalpana,
you, Vanita madam, Shanti madam. Thank you.
Thank you, madam.
Thank you, madam.
There are certain questions in the chat box. I think some PGs have some doubts.
Ma'am, should we tell OGCT or DIPSI single step method, ma'am?
You have to say as OGCT based on DIPSI guidelines. You're safe in saying do an OGCT based on the DIPSI guidelines. Okay, that is the Government of India's technical guideline on the screening for GDM. You say that.
Thank you. Anyway, on behalf of TNFOG, I thank Dr. Vani, Dr. Vanita, Dr. Shanti, and Dr. Vijayalakshmi, and the presenter, Dr. Abhinaya, and Dr. Lavanya. We have 330 registrations today, in spite of changing the dates. So all of you, please attend this program. It is really very, very useful to PGs. And I will send the recording session also for all 10 classes. We have the recording. Anjalakshmi madam, irkingla? I think she is not there. Anyway, we'll thank Dr. Vanita. Thank you so much.
Thank you. Thank you, madam. Thank you so much for the opportunity.
நான் உனக்கு phone try பண்ணிட்டே இருந்தேன், but I couldn't get your phone. Wrong numberனே வந்துச்சு. அதனால தான்
தப்பா நம்பர் போட்டுருப்பீங்க.
ஏதோ தப்பா
I gave the correct number, Shanti.
வனிதா, நீ கொடுத்த நம்பர் தான் போட்டேன். ஆனா அது
wrong. Madam, I gave the correct number only, madam.
கிட்ட பேசவே இல்ல நானு. பாவம், நீங்க சொன்னதோட சரி. She has come. Anyway, thank you, Shanti.
Thank you, madam. Thank you.
Thank you, ma. Shall we leave?
Yes, madam.
இல்லன்னு நினைக்கிறேன். நல்லா பண்ணாங்க வனிதா. பசங்க நல்லா பண்ணாங்க.
Thank you, madam.
Thank you, madam.
Both are well prepared. Abhinaya and Lavanya, all the best for your exams.
Thank you, all the participants also, the presenter. So many participants were there. They are also answered well only. All the best for everyone.
பாப்பாங்க எல்லாம். அதனால உண்மையிலேயே இது யூஸ்ஃபுல்லா இருக்கு. Thank you, Vani madam and Vijay madam, external and internal. We will leave.
Thank you, madam.
Participate much today.
Yes, ma'am.
I was little tired and okay. Okay, Niga, Vijayalakshmi.